Hello, and welcome to our talk on autoimmunity and arthritis. We've got our new rheumatologist here with us. And just to give you a brief introduction, Dr. Gavin is board certified in internal medicine and obtained his Doctor of Osteopathic Medicine degree from Kansas City University of Medicine and Biosciences in Kansas City, Missouri. He completed an internal medicine residency from the University of Texas Medical Branch in Galveston, Texas. He also completed a rheumatology fellowship at Virginia Commonwealth University Health System in Richmond. Dr. Gavin is a member of the American College of Physicians and American College of Rheumatology. He practices at CMH Rheumatology in South Hill in the CARE building next to VCU Health CMH. So you may take it over from here.
Sounds good. Thank you, Christy. All right. Hi, everyone. So I'm talking today about rheumatology and then just a brief introduction and then kind of a little bit about some of the different types of arthritis. So let's see if I can get my slides to advance here. So what is a rheumatologist? Rheumatologist is an internist with additional training in diagnosis of treatment and diseases that affect muscles, bones, joints, ligaments, and tendons. And many of these diseases cause pain, swelling, stiffness, and can potentially cause deformities. So the old-fashioned word for these problems is rheumatism. So rheumatologist, doctor that treats rheumatism. Rheumatologists also specialize in a group of diseases called systemic autoimmune diseases. And there's a couple other similar terms for this group of diseases. Collagen vascular diseases and connective tissue diseases are some of them. So these are a group of diseases with immune system attack on people's own bodies, and this causes inflammation, which results in pain, swelling, and potential organ damage. So these diseases can affect pretty much any part of the body, including the eyes, the skin, the nerves, kidneys, lungs, heart, and pretty much all of the other internal organs. So all systemic autoimmune diseases can cause inflammation of the joints and arthritis as well. So a couple of kind of the more common examples of these diseases are things like rheumatoid arthritis, systemic lupus erythematosus, Sjogren's disease, scleroderma, polymyositis, and vasculitis. And you can see from these names, all of these end in itis. And that's kind of basically the nomenclature, the naming system for inflammation, essentially. And so overall, there are about over 100 different types of arthritis and musculoskeletal conditions. And many of these are based in autoimmune inflammatory arthritis. So some of the history of rheumatology, first kind of defined or discussed in 1st century AD. The term rheuma was kind of what we've talked about already, kind of that old-fashioned term that's derived from the definition of a substance that flows, which is kind of phlegm. So the old medical jargon or kind of thought that the different humors have an effect on different ailments. And then in kind of the 1600s, that kind of system starts to modernize a little bit. Then you get the first concept of rheumatism and a potential concept that a systemic inflammation could be causing arthritis by this guy, Dr. Bayou. So then in 1928, we have the American Committee for Control of Rheumatism. It was established, which eventually evolved into our kind of overarching college, which is what most rheumatologists are a part of, the American College of Rheumatology. And this term, rheumatology, was coined in the 1940s by Dr. Hollander and Dr. Commonwealth. So how common are rheumatic and musculoskeletal disorders in US population? So very, very common, up to 36% of the adult population with a chronic musculoskeletal condition. And about 2/3 of these patients have symptoms significant enough that they see a doctor for them. So about 20% of adults have physician-diagnosed arthritis. And then the prevalence of these musculoskeletal disorders does increase as people age. People over the age of 65, about 56% of men and 69% of women have an arthritis of some variety or another. So non-inflammatory rheumatic diseases are much more common, but inflammatory rheumatic diseases have a risk of about 1 in 12 in women and 1 in 20 in men. So this is just kind of a table looking at a breakdown of the frequency of some of these rheumatic disorders. So arthropathies just means joint problem. And so you can see osteoarthritis is far and away the most common joint problem in patients in the US, with about 12% of people suffering from this. Rheumatoid arthritis is another relatively common. I know 0.6 to 0.8% of the population seems like a small amount, a small frequency, but that's actually ends up being a pretty big number. Crystalline arthritis, which includes gout and pseudogout, is another very common one with up to 4% of the population. And then these connective tissue disorders, which we had kind of mentioned previously, are also relatively common, with the most common ones being osteoporosis, fibromyalgia, and lower back pain and neck pain. Things like lupus, polymyalgia rheumatica, and scleroderma are a little bit less common. So when should you see a rheumatologist? So everyone has muscle, bone, and joint pain from time to time. So when that pain doesn't go away or it continues to worsen, that's when it's worth thinking about getting something checked out. So usually it's best to first talk with your primary care doc about this. And if they think that there is an underlying autoimmune cause, or if they think that a rheumatologist could add further to your care, then they'll refer you to a rheumatologist such as myself. Other healthcare providers, such as physical therapists, occupational therapists, chiropractors, and orthopedic surgeons will often recommend referral to a rheumatologist as well, depending on what their potential differential diagnosis is. So it's also important to think about seeing a rheumatologist earlier if you have a strong family history of autoimmune disease, as these can be significantly hereditary, and if your symptoms are progressing and you have that context of a strong family history, it may be worth getting in to see a rheumatologist sooner rather than later. And then the other thing is that many rheumatic diseases have a kind of relapsing and remitting pattern in that they kind of come and go. So sometimes people will get some initial treatment, their symptoms will get worse, but then they'll keep kind of returning. So when that happens, that's when it's worth thinking about a potential rheumatics etiology. So the other thing to keep in mind about some of our arthritides is that damage can occur to these joints that may be irreversible. And so especially for rheumatoid arthritis and psoriatic arthritis, we want to see patients that have those diagnoses as early as possible so that we can initiate treatment to help prevent progression of that damage and help prevent any type of functional immobility or kind of loss of function of those joints. So it's important to start treatment early and aggressively to try and prevent that damage. So when you go to see a rheumatologist, what are you going to expect? So the first thing we really like to talk a lot, because history is important, and rheumatic diseases can often be kind of difficult to diagnose. And so you telling us your story can be very, very helpful in terms of what your symptoms and what your kind of progression of symptoms has been. Like we mentioned, family history is also very important as well, as many of our diseases do have somewhat of a genetic background to them as well. And then usually we'll try and look through any results that your primary care doc or any of your other physicians may have done. And then we'll talk about what further testing we may need to do, including imaging, and then try and put it all together to see if we can come up with a diagnosis that really puts all the pieces of the puzzle together. And that's the key. I mean, having a correct and accurate diagnosis is going to be the best part of being able to, or the most useful part of developing an accurate treatment plan. So treatment options may include talking with a physical therapist, occupational therapist, going to see another specialist, depending on what organs may or may not be involved. And then kind of talking about whether or not joint or tendon injections may be helpful as well. But many rheumatic diseases, kind of like we've already touched on, are really challenging in that the symptoms come and go, they evolve over time. So often it is a bit of a long process to kind of tease out these clues to kind of come to a correct diagnosis. So it takes some time in many of these complex cases to reach an accurate diagnosis. So in follow-up appointments, we'll talk about these recurring conditions, talk about medications, talk about mechanisms to cope with these diseases, and techniques to try and prevent the disability and loss of function that this joint pain or joint damage may have impacted on your quality of life. All right, so now let's just talk about the basics of arthritis. And I think really simplistically, I like to break it down into the most common inflammatory arthritis that we see, which is rheumatoid arthritis, and the most common non-inflammatory, which is osteoarthritis. And so the way I think about it in kind of general terms is rheumatoid arthritis is a systemic, meaning a entire body disease where your body is producing antibodies that are attacking your joints and causing that inflammation and that damage. Whereas in osteoarthritis, it's much more of a local process. So it's not your body attacking your joint, it's your joint itself, which is having the problem. And that's kind of a complex picture that is kind of evolving in the science currently, but it looks like a combination of degeneration as well as a lack of local repair. But it is not necessarily an autoimmune disease, although there are immune components to it. But yes, so they're very different in that regards, and I think that's the best way to break it down and think about it. And this kind of picture illustrates it pretty well. And so as you can see, in rheumatoid arthritis, you have this kind of large inflamed area around the joint, and that's what we call synovitis, and that's the hallmark of rheumatoid arthritis. And that synovitis is formed of inflammatory cells and immune cells that are attacking and causing this inflammation in the joint. And ultimately, those cells are what cause the damage to the joint, things like erosions and that kind of damage, which ultimately lead to the loss of function and loss of mobility of those joints. Whereas in osteoarthritis, you can kind of see some of the difference here. You have a loss of cartilage, which leads to this kind of bone-on-bone terminology that I'm sure you've probably heard before, and that leads to this painful sensation of kind of the bones rubbing together. And so it's a very distinctly different pathology and progression than what you'll get in rheumatoid arthritis. And so I think that's a good way to kind of think about it. The joints that are involved, even the specific joints in your hands, can give us a clue about whether or not this is osteoarthritis or rheumatoid arthritis, because sometimes it can be a little bit hard to tell, especially early on. So rheumatoid arthritis much more commonly affects the wrists and the big knuckles at the top of your hands, and then these knuckles, kind of the middle knuckles on your fingers as well. Whereas osteoarthritis less commonly affects the wrists or these knuckles, and much more commonly affects kind of the smallest knuckles on your fingers at the end of your fingers, and then the knuckles on the middle of your fingers as well. So this joint distribution can sometimes give us a clue as to which disease is involved, because they are treated very, very differently. So it's important to sort that out. So this is just to go into osteoarthritis a little bit more and just to give some examples of what we see. This is a patient who's had very long-standing severe osteoarthritis. And like I said, these are the knuckles you can see the most distal or farthest away from the hand. And these nodes, or these little bony formations, are called Huberden's nodes. And you can see also they have these knuckles involved as well on these digits, and these are called Bouchard's nodes. But this is just increased bone formation from that kind of bone-on-bone phenomena like we talked about in that earlier picture. In contrast, this is a patient with rheumatoid arthritis, or these are a couple of patients with rheumatoid arthritis. And you can see a lot more involvement of these knuckles at the top of the hand, as well as a lot more deformity. And so they get what's called ulnar deviation, where their fingers will go twist to the outside, and they get these deformities where their fingers will kind of make weird shapes. You can see a lot more wrist involvement as well. There are nodules, and some of these deformities are caused by tendon rupture. And most of these things we do not see in osteoarthritis, and so they help to differentiate the two diseases. And most of these things we can now prevent with a lot of the modern medications we have, the things I'm sure you see TV commercials for it ad nauseum, things like Xeljanz and Humira and that kind of stuff. So these are some resources that I give to a lot of patients, and I think are a really good way to learn more about these diseases if you have any questions, and they go into more detail into some other joint problems as well. But rheumatology.org is the rheumatology site of the American College of Rheumatology. Creaky Joints is kind of a patient support group for patients with autoimmune and joint diseases. And then simpletask.org is a site talking about kind of coping functionally with joint disorders. So just a couple of other kind of topics that I get a lot of questions about from patients with joint pain and with arthritis. So what do we do about diet? Is there any diet that can help with inflammation, and any diet that can help with autoimmune disease? And so, you know, to be honest, there's not great evidence on what's ideal, but we do know a couple of things. Nutrition definitely plays a role in inflammation, but the nuances of how and why we don't fully understand yet. We definitely have seen that, you know, the Western diet in general what we call, sometimes the SAD diet or the standard American diet. Things like a lot of fried foods, high fat, high sugar, high carbohydrates diets does seem to play a role in increased systemic inflammation. So a diet that contrasts that does seem to decrease that a little bit is something called the Mediterranean diet. And that's probably been the most effective diet for people with autoimmune diseases to decrease inflammation. So this is going to be this is not going to be a cure for your disease, but it's something that can be kind of implemented in the context of other medications for autoimmune disease as well. So other things that can help: limit salt, lower glycemic index foods, and some potential benefit from omega-3s. So fat is also pro-inflammatory, so weight loss can also have a very dramatic effect on decreasing systemic inflammation and improving symptoms. So that's another important part of all this as well. And this is just kind of a breakdown of the Mediterranean diet. So it's high in vegetables, fruits, and grains with healthy oils, mostly olive oil, as well as nuts, legumes, and occasional seafood. So it's really avoiding things like red meat and fried foods and high sugar and white flour type things. So it can be a little bit challenging to implement, but I think it's definitely worth the effort. So what about THC and CBD? Once again, we don't really know, and it's obviously a complex medical legal thing as well. So CBD is very poorly studied and very complex because there are many different CBD molecules. And there are a lot of kind of unsubstantiated benefits that you'll see touted for it, including anxiety and vasorelaxant and cardiac benefits and all of these other things you'll see advertised. And really there's been no substantiated or evidence for any of these. There is a meta-analysis. This is, I think, one of the best studies that actually tried to look at some of the trials that have been done in CBD. And this was mostly focused on neuropathic pain as the root cause. So other types of pain, pain like osteoarthritis is more, is less of a neuropathic pain and more of a nocipathic pain. So ultimately, though, they came to the conclusion, which was not the most convincing conclusion in the world, that there's a possible small analgesic benefit. So it does seem to decrease pain in a very small amount compared to placebo. So it's a challenging thing because these medications or these molecules do have some interactions with medicines, and they do have some side effects, and we don't really understand those well yet to use them effectively or safely. So I think those are important things to keep in mind. And then one other thing in terms of all of our diseases, essentially, is exercise. And exercise has effects on the immune system that we use very potent medications to try and replicate. Things like IL-6 decrease. Interleukin-6 is an inflammatory marker, and exercise decreases that. And it also has effects on different types of the adaptive immune system as well, which are all of these are targets of some of our medicines. So if you can impact those through things like physical activity, then you're going to spare yourself a lot of side effects from a potential medicine as well. So I think using physical activity as a medicine is really important and useful for almost all of our diseases. And it is safe, and it has been studied in patients with autoimmune disease and patients with osteoarthritis. So I recommend it for almost everyone. And it has been shown that patients with inflammatory arthritis tend to do better and have better disease and have better or decreased comorbidities as well. So other diseases also improve from this, as it seems like it would make a lot of sense. So these are just kind of some comments about it's been looked at in rheumatoid arthritis, it's been looked at in lupus, it's been looked at in fibromyalgia and scleroderma, and every single time we look at it, it seems more and more effective. So I had left some time for questions, but we can kind of move on. Thank you guys for listening. These are my dogs at home, bored to death by my talk. So please feel free to give me questions or kind of contact me if there's anything I can do. Thank you.
Great. Thank you so much, Dr. Gavin. We really appreciate your time and expertise.
Oh, of course. I hope it helps.
Yes, I definitely learned a lot. If anyone has any questions, you can make an appointment with Dr. Gavin at 584 CARE, and that's 2273. So thanks so much. I'll have a good one.